Hi, my name's Amanda. Thanks for tuning in today to the WeBirth 2019 Virtual Doula Conference. As you may have seen in the program, I'm discussing today why not VBAC, shining a light on the hidden risks and benefits. Women's experiences of discussing the risks and benefits of their next birth after caesarean, NBAC, should include a full and balanced discussion for both elective repeat caesarean section, ERCS, and planned vaginal birth after caesarean, VBAC. How often are the full range and risks of benefits discussed in practicality? Let's review the statistics of uterine rupture, hysterectomy, blood transfusion, and other possible complications for both VBAC and ERCS. We'll explore policies, recommendations, VBAC success rates, some of the road blockages women face, and see what other factors may tip the scales. Plus, we'll look at the other hidden benefits of a vaginal birth. All women deserve the opportunity to truly make an informed decision, as there really is no one-size-fits-all approach. This presentation focuses on the role of a doula in opening up this discussion. I'll be sharing my suggestions on how to best achieve a VBAC. So firstly, please note that this information is appropriate for doulas and birth professionals. It's the key things I feel you need to know to support a woman and her partner, friend, mother, etc., whoever's facing this decision with her. Clients may find it overwhelming and it may not apply in every situation. So if you're a pregnant woman or client and you're watching this presentation, if there's anything in here that's not clear to you, please discuss it with your doula or care provider. And also note that VBAC is a very big topic, so I'm unable to go into great depth here. And this presentation touches on many key issues that I feel you need to know. So a little bit about me. My name's Amanda Bernstein. I'm from Sydney, Australia. I'm a birth and postpartum doula and have been since 2017. I'm now a WeBirth graduate in 2019, and I continue seeking other relevant education, such as a Spinning Babies workshop. I'm a kahuna massage therapist and have been since 2015, plus I'm trained in pregnancy kahuna, Polynesian floor work, lomi lomi heart works, and other relaxation techniques. I've been a Pilates instructor since 2013, and I specialise in pregnancy and postnatal recovery. I'm a VBAC mum myself of two gorgeous boys. You can see them on the right. They're 6 and 4. And I'm personally drawn to the positives of VBAC, and this often isn't well discussed in a way that is helpful to women who have already chosen to VBAC. Let's start by looking at the full range of risks and benefits. So for VBAC, the risks are increased risk of uterine rupture, and this really is the main thing that people worry about when it comes to VBAC. There's also a risk of vaginal tearing or episiotomy and pelvic floor injuries, but please note that these above are risks for mums regardless of a prior caesarean, amongst other risks of a vaginal birth. There's a risk of infection that increases if an attempted VBAC results in a repeat caesarean. There's also several benefits to a VBAC, including maternal satisfaction, physiological birth, normal production of hormones for bonding and breastfeeding, reduced risks for future pregnancies, and a possible shorter postpartum hospital stay. The risks for ERCS are increased risk of infection, hysterectomy, blood transfusion, placenta accreta, dense adhesions, health issues for baby. There's a possible longer postpartum hospital stay, and it may make future pregnancies more difficult as more caesareans equals more risks. And there could be ongoing pain and discomfort around the incision or even numbness. The benefits are convenience, less stress and anxiety about birth, particularly about uterine rupture for birth. It removes the fear of the unknown, and there's a decreased risk of pelvic floor injury. This is an infographic I found just by Googling and looking at Pinterest for words like elective caesarean or VBAC or natural delivery. This one's by Solidify, and I feel that it could be a great way to share with your clients some of the pros and cons around birth and either way that they go. This brochure is called After a Caesarean, and it's presented by ICANN, the International Caesarean Awareness Network. And you can see at the bottom left in blue their website if you'd like to look at this brochure yourself. They ask, Can VBACs and repeat VBACs really be safer than repeat caesareans? Yes, the risk of serious injury to the mother increases progressively with each caesarean her body endures. On the other hand, women who have one successful VBAC lower the risk for themselves and their babies during later VBAC attempts. The greater the number of prior successful VBACs a woman has, the lower her risk of complications for the baby in her current and future pregnancies. Now, the back of this brochure has lots of information on it, so I'll just give you a moment just to look at it. You can see in the middle, there's a black rectangle. And here it talks about the risks of a first caesarean section. So the risk of hysterectomy, blood transfusion, risk of placenta accreta. As you follow the arrow up to the left, it shows the risks associated with repeat caesarean sections for a second, third, and fourth caesarean. And as you scroll down to the right, it shows the risks associated with repeat VBACs, including a first, second, and third VBAC. At the bottom left are the places where they found these statistics, their sources of information. And at the top right, it says, make an informed choice about the risks of repeat caesareans versus VBACs. Caesarean sections are major abdominal surgery, and like all surgery, carry the risks of complications. These can include dense adhesions, excessive scar tissue growth that connects the uterus to surrounding tissues and organs. Adhesions can increase the risks of longer operation times and injury to adjacent organs. The risk of hysterectomy or the surgical removal of the uterus also rises. Undergoing repeated caesareans make it more likely a woman will experience placenta accreta, in which the placenta grows into the middle layer of the uterus, possibly causing hemorrhages and requiring a hysterectomy. A woman who has repeat caesareans can also be more likely to experience thromboembolisms, blood clots that break loose and block blood vessels, or excessive blood loss. And while uterine rupture, a rare but potentially catastrophic event during pregnancy or childbirth in which the uterine wall splits open, remains a concern after one or more caesareans, the risk of uterine rupture is small and it decreases further with each additional VBAC. Here's an infographic of the ICAN brochure. You may have seen this one in pink on the left. I've seen it the most out of 3 that I've found for you. Here's the second one in blue and one more with trees behind it. But they all look at the risks of comparing a VBAC and repeat caesarean, and they take their data from that ICAN brochure we just went through. So there are many VBAC policies and guidelines, and I looked through a broad range. Because I'm based in Australia, I found one from quite a few of our states, New South Wales, Victoria, Queensland, South Australia, Western Australia, and I also found some from the UK and the USA. And I noticed or thought to myself, why isn't there just one VBAC policy or guideline? When you break it down, either by hospital for within a certain hospital with a public or a private patient, they can be treated completely differently. And different hospitals within the state, or when you vary by state or by country or even developed or developing nations, there's just so many variances. But here's what I found as the common recommendations or suggestions. Firstly, spontaneous labour. Your chances for a successful VBAC increases if you go into labour on your own and present at hospital with the cervix at least 4 centimetres dilated. The risk of uterine rupture rises slightly if you're induced. Continuous electronic fetal monitoring. Now, we know in general that the scientific basis for electronic fetal monitoring is weak, and it's up to the interpretation of the expert that's viewing it. However, when it comes to VBAC, it's recommended for established labour. Several VBAC studies have reported that in over 70% of cases of uterine rupture, the first signs or symptoms presented as prolonged fetal bradycardia. Of these cases, only 8% presented with pain and 3% with bleeding. In general, they recommend more than 18 months gap from your previous C-section before your attempted VBAC. And this depends on which document you read, as sometimes they say more than 24 months gap. They suggest no more than 1 or 2 previous C-sections. And of course, this depends which document you read, as they offer different suggestions. There's a suggestion that the BMI of the mother is less than 30 so that she manages her weight. And a 2013 study showed that overweight women who lost at least one body mass index unit increased their chance for a successful VBAC by 12%. And that's compared to overweight women who maintain their weight. Some policy suggests the mother should be taller than 150 centimetres. And then we've got the baby's birth weight. It's suggested that the baby's birth weight's less than 4 kilos. And Belly Belly, a blog, you can check it out, bellybelly.com.au, has an article that suggests it's important to know that there is a recognised 15% error in ultrasound fetal weight estimation. So when we look across the policies and guidelines and we look at the VBAC contraindications, the main one seems to be if you've had 2 or more previous caesarean sections. There's also a contraindication if you've had a previous classical caesarean with even an inverted T or J incision versus the more modern and more often used lower segment caesarean. And you can see an image on the right here. One woman has a dotted vertical line, and that's the previous classical incision. And if you made that like an upside down capital T or a J, that would be the inverted T or J incision. The one on the right shows the lower segment caesarean section, which is often referred to as LSCS. A previous uterine rupture, a myomectomy, which is a fibroid removal that breached the uterine cavity. So on the right in the second image there, you can see various types of fibroids of the uterus. And if it breached the uterine cavity, that's considered a contraindication. Or there may be medical or obstetric reasons for a repeat caesarean. For example, a woman may have placenta previa. I've worked with clients before that have spinal disc fusions, or the woman may have preeclampsia, etc. And there are other medical and obstetric reasons that are worthy or legitimate or necessary reasons for a repeat caesarean rather than a VBAC. The New South Wales Health Guidelines, and here's a link down the bottom left in blue. They state that over the last 30 years, a growing number of studies have suggested that babies born at term by vaginal delivery have significantly different physiology at birth to those born by a caesarean section, particularly when there has been no exposure to labour. Some of the effects of caesarean section are short-term, for example, impaired lung function, reduced thermogenic response, and alteration to metabolism, feeding, immune phenotype, and blood pressure. But longer-term problems are also apparent. For example, increase in immune-related conditions such as asthma, alteration in metabolism leading to obesity, and neurological and stress-related problems. It is suggested that vaginal delivery initiates important physiological trajectories, and the absence of the stimulus in caesarean section has implications for adult health. The South Australian Clinical Guideline, and you can see the link down the bottom there in blue again, states that compared with repeat caesarean section, women who give birth vaginally have lower morbidity and fewer postpartum complications. In developed countries, the incidence of any type of uterine rupture after caesarean section is estimated to be 0.5 to 1%. An Australian study has shown that, irrespective of whether oxytocin or prostaglandins are used, induction of labour and augmentation of labour in women with a previous caesarean section increases the risk of uterine rupture compared with spontaneous labour. Now, I just want to draw attention to the word oxytocin here, and while it's used correctly, I feel our role as doulas is to highlight that oxytocin that is injected as a drug is different to what our bodies produce gradually and incrementally throughout a labour. I believe we should be referring to it as syntocinon or pitocin, and they're the names of the brands of the drug. And often I'm at the hospital and they use the word oxytocin, and I think it's important for us to help clarify for our clients that it's not exactly the same thing, and it does behave differently in our body. So if we look at VBAC success rates from the Queensland Clinical Guidelines, and again the link is at the bottom left in blue, they state that in 2013 in Queensland, 118 per 1,000 women at term gestation experienced their next birth after primary C-section. Where? 719 per 1,000 women had a repeat C-section with no labour. 632 per 1,000 women who spontaneously laboured had a VBAC. 678 per 1,000 women who were induced had a VBAC. The recorded uterine rupture rate for the women who spontaneously laboured or were induced was 5 per 1,000 women. So if you're like me, I prefer percentages to per 1,000, and I've just put them there on the right for you. Let's look at the types of uterine rupture. In Dr. Rachel Reed's article, VBAC, Making a Mountain Out of a Molehill, which is published in June 2016, she writes, there are two types of rupture associated with VBAC. Catastrophic, which is symptomatic. The old scar separates along its length, the amniotic sac ruptures, and the baby is pushed into the abdominal cavity. This results in significant bleeding, shock, and the baby is in grave danger. Asymptomatic. The scar separates part way along its length, the amniotic sac stays intact, and the baby remains in the uterus. Bleeding and shock is minimal, and the baby usually survives. This is the most common type. So out of the smaller number of women who experience uterine rupture, an even smaller proportion will lose their baby or uterus because of it. When the uterus ruptures, 94% of babies survive. The ERCS guidelines, and that's the Royal College of Obstetricians and Gynecologists, and Rachel refers to this in her article, states that women should be informed that the absolute risk of birth-related perinatal death associated with VBAC is extremely low and comparable to the risk for nulliparous women in labour. And there are two links down the bottom left for you, one to Midwife Thinking, which is Rachel's blog, and the other to the ERCS website. So I ask, if only 6% of the 0.5 to 1% of ruptures are catastrophic, that means the risk of baby dying is 0.03 to 0.06%. So why do we make such a fuss of VBAC, especially when, according to ERCS, it's comparable to first-time mums? I found an online tool, the link again is down the bottom left. It's a VBAC success calculator, and I popped in all the details for myself when I had my VBAC in 2014. So my age, my weight, my height, and my background. And it said I had a 71.7% chance of a predicted successful vaginal birth. And I had one, which is great. But you should note that the predicted chance changes if the variables are altered. So, for example, if I was older or healthier, or if I had had a previous vaginal delivery, those all impact it. So I think a big question here is, why would a woman choose an elective repeat caesarean? And I think the first thing that we should acknowledge is the risk of rupture. So while the risk of rupture to me feels relatively insignificant, if you're the one that it happens to, it's very significant. There's also a convenience factor, being able to lock in a date and a time, or know that your obstetrician is available, for example, or if your partner travels, that sort of thing. There could be fear of the unknown or fear of pain in labour. There's fear of potential vaginal tearing and pelvic floor issues. And there's often a perception of less risk, that the C-section is a controlled environment. Some women prefer an elective caesarean to another emergency if their VBAC attempt doesn't go well. There may be a lack of support by care providers. And we still often use phrases like, once a caesarean, always a caesarean. There's a belief in the expert, and that is that the doctor is the expert, that women are following the recommendations of the expert, whereas I personally feel that women should be considered the expert. And some women feel they just can't do it, and whether it's because they don't have faith or belief in themselves, or maybe they've been told that they've got a small pelvis or their baby's too big or whatever it might be, some women truly feel that they can't do it and they would choose an elective repeat caesarean. So let's look at some of the roadblocks to a VBAC. The first is hospital policy, and this can place limitations on women. For example, a VBAC woman may be given a limit of 1 hour to push her baby out. Unsupportive care providers or unsupportive partners and family, that's definitely a big roadblock. Women may be seen as going against medical advice. So why is it encouraged to seek a second opinion in all other medical fields except obstetrics? Maternal age. A 2007 study found that women younger than 35 were more successful and had fewer complications during a VBAC. And some of the policies that I looked at actually suggested that women should be under 40 years old. There's an unspoken societal belief that babies' welfare comes first. I'm not sure if you've ever heard the term, all that matters is a healthy baby. And I think that, mums are expected that they should just do as they're told and not risk their baby. They're often told that they're being selfish for wanting to have a natural birth. There can be fear and guilt of needing to be a good patient. And there's also fear of taking back control. If the doctor decides it for them, it releases them of the responsibility. But if they make the choice, it's all on them. And if something goes wrong, they don't want that responsibility. There may be a lack of village, which means scheduling in an elective repeat caesarean or an induction to ensure that their partner that's on leave and is available and they've got a babysitter for their older kids that can be arranged. And perhaps their obstetrician is going to be on leave, so they need to make it a date that their obstetrician's around. There are misconceptions around the safety of an elective repeat caesarean and a VBAC. The thoughts are that ERCS is safer and controlled, while a VBAC is dangerous and also the unknown, especially if they've not had a vaginal birth before. And usually VBAC women, when they arrive at the hospital, have a cannula inserted. And I feel this sets the expectation or the anticipation of something going wrong later in labour, as though there's going to be a failure of some kind. And this can undermine a woman's self-belief. I truly believe there's no one-size-fits-all approach. As you've seen above, the policies and guidelines and recommendations vary by hospital and by care provider. We also need to take other factors into consideration, including medical and personal background or perception. We all perceive risk differently, so the choice that may be right for you or me may differ from any care provider, best friend, mother, etc. And I believe women must feel confident and supported in their decisions, which again may differ from what anyone else may choose. So one size doesn't fit all. What else should we consider? Firstly, microbiome or seeding. Maternal satisfaction, the sense of accomplishment that I did it. And I truly believe that all women are amazing at growing and birthing their babies, no matter how they birth their babies. Hormones and comfort for bonding and breastfeeding. The impact on future pregnancies and births. What if they want a larger family, like 4 or more kids? Postnatal depression or PTSD. And I feel we need to debrief and prepare well for fears or concerns, and whether it's from their past C-section leading forward to a VBAC or whether they, might not achieve a VBAC. These are things we need to consider. Also, the impact of drugs and medication in the body or our system, and the time of recovery or healing. What about if they're chasing a toddler? Or up above, the hormones and comfort for bonding and breastfeeding. If they're struggling with pain from a C-section, they may struggle with bonding and breastfeeding as well. So as doulas, how can we best support women? And couples, of course. I think it's when we know the actual statistics for VBAC success, when we are aware of the full range of risks and benefits, when we see the variety of recommendations, when we can foresee the roadblocks, when we understand that each client with their own specific circumstances deserves individual management. They aren't just a statistic. For example, they may have past trauma that would need clearing, or they may have gestational diabetes, or whatever else might be going on for them. As doulas, we need to allow our clients to make this NBAC their own. We need to be careful not to influence on their choices. We need to be unattached emotionally ourselves and separate our own feelings, which can be really difficult to do. I know I still struggle with this sometimes. And supporting mums wherever they are at with no judgment. Our role is to be there for these women no matter what. And ultimately, our role as doulas is to encourage, to nurture and nourish. Don't set a woman up for failure if the NBAC ends in a repeat caesarean. She still did it. We need to encourage positivity in any birth. So here are my top 7 tips for women to achieve a VBAC. 1. Believe in and trust yourself and surround yourself by a supportive network of partner, family, friends who are on board. Ensure you have a supportive medical care provider and hire an experienced doula who truly supports your decisions. And of course, I may be a bit biased. 3. Seek quality, independent childbirth education and tools for natural labour and birth. Debrief. Not just deconstruct, but debrief as well. Any past birth experiences. Don't carry past trauma to your next birth. Know that you can truly consent or decline anything. Empower yourself and take control of your birthing experience. 6. Use the BRAINS acronym. So if you haven't heard of this before, go to Google and look at the images for BRAINS. What are the benefits for any intervention or procedure that's been proposed to you? What are the risks? A is for alternatives. I is for intuition. What does your gut tell you? N is for nothing. What if we do nothing? And S stands for space or for time. Ask for time to discuss and decide, to make an individual choice that's right for you. And 7, feel confident in your decisions. No matter what, you've tried your best and utilised every possible technique, tool, tip, and strategy. So thanks for tuning in and listening to me today. I hope you found it beneficial and helpful. Here are my contact details, and please, by all means, get in touch. I'm happy to answer any questions. If you have anything that you want to discuss or go over, I'm more than happy to chat. It's been an honour presenting to you today as part of the WeBirth 2019 Virtual Doula Conference. Thank you.